Welcome to our free Next Gen NCLEX review session today. We're so glad you guys are here. We're going to just take a quick minute and make sure we are up and running on all of our channels. So feel free to start using that chat feature. Let us know where you're coming from. Happy Thursday. We're rounding this week out with our series called Tough Topics. And today we're going to talk about electrolytes, specifically potassium. So give us just a quick minute and we will get started in just a second. Let's see who we've got here. Awesome. We have Blessy joining us from YouTube. Hi, Blessy. All right. I will just do a quick check-in and make sure we're good to go. All right. Okay, so welcome back, everybody. I think we're going to get started now. My name is Jackie, and I'm a nurse here at UWorld. I work on our nursing content team, and I've really enjoyed being here with you guys for these live and learns. Today, our topic is electrolytes, and we're specifically going to be talking about potassium. So we're going to do more of these electrolyte videos, but today we're just going to focus on potassium. So as always, a refresher on our schedule. We are here Tuesdays and Thursdays at noon Central Time. You can find us on your favorite social media channels, subscribe, like, follow, all the things, and get updates on our schedule and our topics and when we go live. And if you guys are willing, I want to encourage all of you, especially if you're on TikTok today, go ahead and share this live with your friends. Invite them to join us and learn about electrolytes. The more the merrier. So share the news, let people know we're out here, and invite them to join us today. So as always, we have on-demand viewing available on YouTube and Facebook. And also, if any of you guys are in Orlando at the National Student Nurse Association Conference, we have a booth set up. So make sure and swing by, say hello to our friends there. And we'd love to hear from you and love to see you there. Again, so looking ahead to next week, we're going to be focusing on tackling NGN item types like case studies. And so these are like the new item types that are outside of the select all that apply and also from single best items as well. So we'll be live Tuesday and Thursday at noon Central Time. Again, today we're kicking off electrolytes, specifically potassium. So we're going to talk high potassium or hyperkalemia, and we're going to talk low potassium or hypokalemia. So we're going to reference what our test plan says about electrolytes. We've talked about that before. And I'm going to give you a piece of like mic drop information if you haven't heard it. So stay tuned on that. Maybe you've heard it and it's not really mic drop information for you, but more to come on that. And then we're going to walk through some of the ins and outs of what you need to know about electrolytes. So as always, we'll have practice questions at the end, but we're saving that to the end, so stay tuned. And then as always, drop your comments in your chat, ask questions, let us know how you're doing, let us know how we're doing, and we have our team of experts on board to answer those questions for you. All right, so let's start with the test plan. So we've said this several times, but the NCSBN, which is the makers of the NCLEX, they publish amazing resources for nursing students to review before they take the NCLEX. So one of these items is the test plan. So it breaks down, the test plan really breaks down the information into that we have on the test into client need categories and activity statements. So I want to read to you guys what it says about electrolytes. So under physiological adaptation client need category, which is essentially the category that's covering everything related to disease processes, the activity statement is going to read, manage the care of the client with a fluid and electrolyte imbalance. Okay. So then more specifically, it's going to tell us exactly what we need to know. So identify signs and symptoms of client fluid and or electrolyte imbalance, apply knowledge and pathophysiology when caring for the client with fluid and electrolyte imbalance, manage the care of the client with a fluid and electrolyte imbalance, and evaluate the client's response to interventions to correct fluid and electrolyte imbalance. So again, that's a lot, but we're going to use that to kind of guide our discussion today. Okay, so let's talk about what on earth potassium is and what it does in our body. And I want you guys to just stick with me for this first part. We're going to get a little bit into the weeds of chemistry, but it's going to be totally okay. Okay, so if you had to like make your Mount Rushmore of electrolytes, or if you had to pick a top 3 or top 1, I would probably say potassium is going to be on there. It's going to be your number 1. It's really like the MVP of electrolytes. So it's an important intracellular ion, meaning it mainly lives inside cells, and its role is to control the fluid volume inside of cells. So how it moves in and out of cells is what allows cells essentially to activate or do their job, and we are going to talk a little more about that. So I don't want to get too far into the weeds of these things, but we're going to take just a quick trip down our chemistry memory lane and talk about the sodium-potassium pump. So we have a little image that we're going to show you guys that'll kind of illustrate this a little bit, but this pump is a critical protein that's found on the cell membrane, and it's used to create an action potential of a cell, which is pretty much what it says it is, potential. So essentially, it's slowly preparing the cell so it can do its job. So the sodium-potassium pump is responsible for creating action potential for cell membranes. So think of the pump like this. Okay, so it's going to open to the inside, so it's going to open to the inside of the cell first, and it's going to grab 3 sodium ions. Sodium is a positively charged ion. The pump is like, great, full crowd on my sodium side. I'm going to drop these guys off into the extracellular fluid, or like our bloodstream. I'm going to pick up 2 potassium, and I'm going to bring them inside of the cell. Potassium, again, is a positively charged ion. The thing that's really cool about the sodium-potassium pump is that it forces these electrolytes into a space where they have higher concentrations. So it's using energy like ATP to do what it's doing. So sodium is moving from lower concentrations in the cell to higher concentrations outside the cell. So it's swimming upstream. Same with potassium. Potassium is moving from lower concentrations outside of the cell to higher concentrations inside the cell. Same idea, it's swimming upstream. This whole process is called active transport. So biggest takeaway from all of this is that to exchange sodium and potassium, it's important to know about this, because when it comes into play when we're talking about influencing muscle function. So we need these ions to move in and out of cells to get our muscles to work correctly, especially when it comes to some of our essential muscles like cardiac muscles, skeletal muscles, smooth muscles like those in our GI tract. Okay, so knowing that potassium should live in higher concentrations inside our cell, let's learn what a normal range is for potassium, and then we'll walk through serum potassium, high serum potassium, which is hyperkalemia, emia meaning in the blood, hyper meaning high, cal meaning potassium, K, and low serum potassium, or hypokalemia. Okay, so a normal range for potassium is 3.5 to 5 milliequivalents per liter or millimoles per liter. Okay, so hyperkalemia is a value greater than 5, and hypokalemia is a value less than 3.5. Okay, this is the big mic drop news alert for you guys. Maybe you've heard this, but just be excited because I'm going to tell it to you again. Okay, so for the next-gen NCLEX, you do not need to memorize lab ranges. You do not need to know these reference ranges. If you go into the FAQ section of NCLEX.com, it's going to tell you what you need to know about reference ranges and lab values, and you don't need to know anything. They're going to provide you with all of that on the test. So that is one of the changes that happened when we switched from the old NCLEX to the new next-gen NCLEX. So you don't need to know reference ranges for lab values. So, but I will say this, you probably need to know them for nursing school, so just keep memorizing them, but do know that is what you'll see on test day. You'll be given reference ranges. Okay, so I hope that's good news. Okay, but back to potassium. Let's talk about what can cause our potassium to get too high and what happens in our body when that happens. So let's talk causes of hyperkalemia or high potassium. So big picture, we either took too much in or we didn't get enough out. Or potassium is stuck out of the cell potassium has snuck out of our cell into the bloodstream. So this can look like a large intake of potassium either through diet or electrolyte replacement for hypokalemia. So we might have overcorrected. This is, again, an example of taking in too much potassium. But more likely, clients will probably get hyperkalemia from impaired kidney function. So potassium is excreted through our kidneys and our urine. So things like acute or chronic kidney disease, think elevated serum creatinine creatinine, or decreased GFR, our glomerular filtration rate, these things can cause hyperkalemia because our filters aren't working and we aren't making enough urine. Medications can also cause hyperkalemia, so things like potassium-sparing diuretics like spironolactone, or medications that reduce aldosterone secretion like ACE inhibitors. There's also a few conditions we should talk about that cause hyperkalemia, so let's talk about DKA or diabetic ketoacidosis. We'll definitely do a video on this. It's such a big topic and something we can really dive deep into, but we're going to talk about just some of the basics of it. Okay, so when you have diabetic ketoacidosis, your body is in metabolic acidosis. So we talked on Tuesday about the pH scale, and essentially it's a scale of hydrogen ion concentration in the blood. So the more hydrogen ions in our blood, the more acidic we are. So potassium and hydrogen have a direct relationship. So in DKA, we experience metabolic acidosis. So we have a higher concentration of hydrogen ions in our blood, so we can also expect to have a higher concentration of potassium ions in our blood as well. So in the same vein as DKA, we need to talk about insulin deficiency and hyperglycemia. So DKA is essentially extreme hyperglycemia. So it kind of all fits together when you think about it. So you might have learned that insulin moves glucose from our blood into our cells. It does the same with potassium too. So if we have insulin deficiency or low levels of circulating insulin, we're going to have high levels of potassium outside of the blood. So conditions, again, so this is going to tie back in hyperkalemia, DKA, hyperkalemia. Conditions that cause cell destruction can also cause hyperkalemia. So think of our cells as balloons, and the potassium is like glitter or confetti being stored inside that balloon. So think about rhabdomyolysis and tumor lysis syndrome. So in short for rhabdomyolysis, essentially we have a breakdown of our muscles. So think bursting muscle cells. Since potassium is stored inside the cell, when it bursts, there's going to be potassium confetti like all in our bloodstream, and that's going to cause hyperkalemia. Same principle with tumor lysis syndrome. When clients have a high cancer burden in their blood and they begin chemotherapy, the lysis or the breakdown of those cells is going to cause that glitter again to explode in our bloodstream, potassium everywhere. It's going to cause hyperkalemia. So those are some reasons, some causes of hyperkalemia, things that elevate our serum potassium. Okay, so what does a client with hyperkalemia look like? I want you just to think very broadly. Think weak muscle problems. Okay, so think of hyperkalemia this way. We know potassium should live inside our cells. If we have too much potassium outside of our cells, we could maybe assume that our potassium tank in our cells is low. So instead of our cells being able to go up to like 100 miles an hour, they're only going like 40 miles an hour, so they can't reach their full potential. So we talked in the beginning about how the exchange of sodium and potassium is important when it comes to influencing muscle cell function. So when we think about important muscles, we should think about our heart, like probably number one. So tie this all together. If a client has hyperkalemia, we are going to worry about changes to the electrical conduction of their heart, or ECG changes. So high potassium can result in tall peak T waves and the absence of P waves. So think high K, high T. It can also lead to heart block. So when I think muscle problems, specifically when I think weak muscle problems, I think poor conduction and communication within the muscle itself. So that's how I kind of think about how heart block ties into this. So signals aren't quite making it through the heart. So again, thinking weak muscle problems, clients with hyperkalemia can experience ascending paralysis, or paralysis that starts in the lower extremities and works its way up. So similar to Guillain-Barré syndrome. Okay, so knowing all of this, let's talk about some complications. We're mostly worried about fatal dysrhythmias. So if hyperkalemia goes on too long, our client can progress from peak T waves to VFib to asystole. So again, thinking weak muscle problems, weak conduction, weak communication, all that put together really paints a picture of asystole, or no communication in our heart. It's a total breakdown of the heart muscle and the heart electrical system. Okay, so we've made it to complications. We're going to talk treatment, and then we'll take a little breather. Okay, So treatment, first things first, we always want to monitor our electrolyte levels. We want to get baseline information, and we want to collect information as we go throughout our treatment to make sure we're headed in the right direction. As we've always said, baseline treatment, we have to know where we are to know where we want to go. Okay, so, but pretty simple, we want to decrease the potassium levels typically by increasing potassium excretion. So we want to get potassium out of our body. So we talked about in the beginning that potassium is excreted through the kidneys. So we want to give medications like potassium wasting diuretics like furosemide, or oral potassium binders like I'm going to say this wrong, patiromer, which is like also known as Veltassa, and sodium polystyrene sulfonate or KXLate. That's what you're going to hear it like in the hospital, but you need to know these generic names for the NCLEX. Okay. These medications excrete potassium through the GI tract. Okay, if our kidneys are impaired though, dialysis may be needed. So essentially we're going to need a machine that's going to take over the function of our kidneys and filter blood to normal levels again. Circling back to insulin, we said earlier that insulin drives glucose and potassium into the cell. So hyperkalemia protocol typically involves insulin administration. So we can give regular insulin IV, and only regular insulin can be given IV. So that's a big safety thing to know for the NCLEX. We covered that on our Mythbusters Med Edition. So if you haven't seen that one, go back and check it out. But again, only regular insulin can be given IV. But we also need to add in some IV dextrose because we don't want to make our client hypoglycemic, because again, insulin is going to take both potassium and glucose into the cell. I like envision it, insulin is like a person with two backpacks on, and they have like a key card and they're walking into the cell. Okay. I don't know if that helps you guys. Okay, so then we also need to make sure and monitor these clients with continuous cardiac monitoring. So again, our big muscle that's kind of implicated with all of this is our heart. So we need to monitor our heart, and we need to make sure our heart is stable. So if we see some ECG changes starting to happen that indicate things are not good and our myocardial cells are having some irritability, we really need to administer a medicine like IV calcium gluconate to help stabilize these cells. So again, some changes to certain electrolytes are going to impact the activity of other electrolytes. So we need to give IV calcium gluconate if our heart seems to be a little bit fidgety from high potassium. Okay, last but not least, nutrition. So we need to obviously avoid foods that are high in potassium, some foods like bananas, cantaloupe, avocado, spinach, things like that. So this is a big, with electrolytes of any kind, we need to know foods that are rich in these electrolytes and foods that we should avoid. So in this case, we want to avoid foods that are high in potassium. Okay. I know that was a lot. We're going to take a breath and before we switch to hypokalemia, and I'm going to just ask you guys a quick knowledge check question. So use the chat function, let us know, but the question is, let us know some causes of hyperkalemia. So what can cause that elevated serum potassium in our blood? Let's see what we got. Cool. Awesome. The chat's starting to come in. I'm seeing some things from Facebook and YouTube and TikTok, so thank you guys so much. Again, we're looking for some causes of hyperkalemia. Let's see what you guys got. Awesome. I'm seeing tumor lysis syndrome, renal impairment, renal failure. This is great. DKA. Yes, a lot of DKA. Facebook is saying DKA. Good job, guys. Very, very good. All right. I think you're getting it. We're going to move on now to hypokalemia. This one's a little bit easier. Okay. So again, quick reminder, hypokalemia or low levels of potassium in the blood would equate to levels less than 3.5 milliequivalents per liter or millimoles per liter. Okay, so let's talk causes of hypokalemia now. Big picture. Think potassium is going out of the body or potassium is going into the cell. So visualize a person and our starting point is going to be like the stomach or the abdomen. So anything going up like vomiting or NG tube suction, or anything going down like diarrhea or increased urination. So this can be from meds like potassium wasting diuretics like furosemide, or conditions that increase urination or polyuria, or hyperaldosteronism. So aldosterone increases potassium excretion from the urine. So if we have increasing aldosterone, we are losing more potassium. Okay, so now let's think about conditions that shift potassium into the cell from the blood. So think about our treatment for hyperkalemia, which is insulin. Too much insulin can cause hypokalemia and hypoglycemia. So potassium and glucose, again, are directly related. So again, our treatment for hyperkalemia can cause hypokalemia. For hyperkalemia also, we talked about metabolic acidosis. So the opposite is true for hypokalemia, which would mean alkalosis. So again, on the other end of that pH spectrum. So again, since hydrogen and potassium are directly related, when we have alkalosis, that means we have low hydrogen ion concentration and we have low potassium ion concentration in our blood. Okay. So those are kind of a little bit more about the causes of hypokalemia. Now we're going to talk about clinical features of hypokalemia, so what we see in a person with hypokalemia. Okay, so kind of relating this back to what we learned about hyperkalemia. Since with hyperkalemia, since there is too much potassium in the blood and not enough in the cells, we visualized our cells like not working to their full potential. So let's swap that now for hypokalemia. We can visualize too much potassium in our cells and not enough in our blood, since again, hypokalemia is a measure of potassium in the blood. So if our cells have too much potassium, they're going to be like over-caffeinated and jittery. They're just going to be like, ah! Okay, so same principle as with hyperkalemia. Our heart is a muscle and potassium really affects our muscle conduction, and we are thinking jittery with hypokalemia. So think ECG findings like PACs and PVCs, so premature atrial contractions and premature ventricular contractions. So our atrium and our ventricles, they're way too excited and they're jittery and they're firing way too fast. So again, think about it that way. Clients can also experience dysrhythmias like VTAC and VFib. So VTAC, our ventricle is going way too fast, super glitchy. We can also get muscle cramps. So muscle cramps kind of make me think of like one big jitter or one big glitch. So again, hypokalemia. Our smooth muscles in our GI system can also be affected by hypokalemia. So these clients can have nausea and vomiting. They can also have decreased bowel sounds and constipation. Okay. So how do we treat hypokalemia? We know what it's caused by. We know what it looks like. How do we fix it? We also know about hyperkalemia, so we're going to kind of take an approach like that. Okay, so as always, first things first, we need our baseline information, and we need to track our progress as treatment is going. So we're going to take baseline electrolyte levels, and we're going to take repeat levels as we give treatment as well. Okay, we need to be sure that these clients are also on continuous cardiac monitoring, since we know potassium affects our heart. So again, same thing. Muscles, think heart when you think potassium. Okay, but pure and simple, we just want to stop potassium from leaving our body. So we need to avoid potassium wasting diuretics like furosemide, and we may need to swap our diuretic out for a potassium sparing diuretic like spironolactone. So opposite from hyperkalemia. We also want to stop any GI losses of potassium from diarrhea or vomiting, so we may need to give medications like antiemetics like ondansetron or antidiarrheals like loperamide. But most commonly, what you will do to correct a hypokalemic imbalance or low potassium is just to give potassium, so giving potassium chloride. So potassium is a high alert medication, so there's a few things we need to know when we're giving potassium. First, you can only give it orally or in an IV piggyback. So those are the only methods of administration. It's also a vesicant, so you have to be sure and monitor your IV site or where it's getting infused. We want to make sure that our vessels, our infrastructure can maintain the medicine going in. We also never want to give this medication as an IV push. This can be fatal to the client and fatal to the heart muscle, or fatal to the heart muscle, which would be fatal to the client. So our cells can't navigate that quick influx of potassium. It needs to be delivered at a very specific threshold or a very specific rate. So if we're giving IV potassium chloride, we should never give it at a rate greater than 10 milliequivalents or 10 millimoles per hour. So again, whenever you're replacing potassium, you'll have a protocol and you want to follow that, but you never want to give potassium faster than you should. You should only infuse it at no faster than 10 milligrams, or 10 milliequivalents or 10 millimoles per hour. Okay. Lastly, we said in hyperkalemia to avoid foods that are high in potassium. Hypokalemia, we want to encourage foods that are high in potassium. So all the things we said to avoid in hyperkalemia, we're going to consume. So bananas, strawberries, spinach, cantaloupe, avocados. There's so many more. Okay, that's kind of it. That was it. We made it through potassium. We're going to pull up 2 questions for you guys, and we're going to walk through it. So I will give a second for those to come up, and I will read the question, and I'll give you guys a second to answer, and then we'll walk through our explanation. Okay, so first question says, the nurse is caring for a client with chronic kidney disease. The nurse notes tall peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Okay, so I'm going to give you guys a second. Put your answer in the chat, and we're going to talk through this question and also what it means that it's a priority question as well. So let's see what you guys come up with. Drop your answers in the chat. Let's see what we've got. I'm starting to see some things come in. YouTube, Jacob and Nisa and Christian, Peter, good job. I've seen a lot of option 1s come in. Facebook, Jacqueline and Sarah and Anna said 1. You guys are correct. Okay, so let's walk through this. First, starting with the question. So we're seeing client has CKD. So we know their kidneys are impaired. We're also seeing tall peak T waves, so we learned high K, high T. So I'm thinking hyperkalemia. We have too much potassium in our blood. And they're on continuous cardiac monitor. Great, they should be. Okay, so which of the following actions would be a priority for the nurse to take? So this is what is the one most important thing that they need to do out of our options. So priority is really narrowing us down to the most important option, like our VIP option choice here. Okay, so option 1, administer IV calcium gluconate to the client. Okay, so if there are ECG changes with hyperkalemia, it's a priority for the nurse to administer IV calcium gluconate. Again, the whole point of doing this is to reduce that myocardial irritability and protect the myocardium from potassium dysrhythmias. So we're thinking in this case ABCs. So when we think C, we're thinking circulation, we're thinking our heart. So this is definitely going to be a priority, but we're going to go through the other options and kind of see why they're not a priority. Okay, so option 2, teach the client to limit dietary intake and potassium. Definitely, they have hyperkalemia. They should limit what they're taking in, but this can wait. This is something we do at the end. We're not going to tell them as their heart is like having issues to stop eating potassium. We need to address the root cause of the problem, which is the heart. Okay, request a prescription for oral sodium polyKXlate for the client. Again, this is going to help, but it's not the priority that we need to do. It's going to take a little bit of time. We need to take action and protect our heart first. Okay, option 4, prepare the client for placement of a temporary catheter for hemodialysis. Again, this might be something we need to do, especially if they have CKD. They might require dialysis, but again, this is going to take time. We need to stabilize the heart first, so that's why we're going to give IV calcium gluconate to the client. Okay, very good. Last question. Okay, and we're doing good on our time here. Okay, so our last question is, I'll read it, let you guys answer, and then we'll go through it all together. Okay, the nurse is collecting data from a client with heart failure who is receiving furosemide. Which of the following findings would indicate the client is experiencing an adverse effect of furosemide? And I will give you some time to answer. Our chat, awesome, very good. Let's see what's coming in. Drop your answers in the chat. Good job, guys. I'm starting to see. Yes, very, very good, you guys. I'm seeing a lot of option 2s. Very good. Oh, perfect. Awesome. Oh my goodness, you guys are flying. Okay. Very good. Awesome. Okay, so we'll go through the answers and the STEM as always, and then see if you guys got it right. Okay, so heart failure furosemide. Okay, we know furosemide is a potassium wasting diuretic, so we are going to think hypokalemia is an adverse effect of this medication. Okay, so option 1. 2+ pitting edema in the bilateral lower extremities. So if they have heart failure, we're going to think they probably have some fluid retention. So 2+ maybe is an improvement. I'm not going to think the diuretic is not going to cause it. It's going to help it. So this is not an adverse effect of it. Okay. Option 2, muscle cramps during ambulation. Okay, so I'm thinking muscle cramps. We talked about with hypokalemia, that kind of glitchy feeling or that glitchy muscle activity that over-caffeinated. So cramps was one of them. So muscle cramps would maybe indicate that furosemide is wasting too much of our potassium. So I'm guessing this is my correct answer, but we're going to carry on. Okay, so then option 3, fine crackles in the lung bases. So again, this would be a finding associated with heart failure, but it wouldn't be something that the medication would cause. Furosemide is not going to cause crackles. It's going to help treat crackles, so that fluid overload from our heart failure. Okay, and then option 4, increased urinary frequency. That's essentially how a diuretic works. So we wouldn't be alarmed if they're urinating a lot. We would be alarmed if they weren't. So that is definitely not an adverse effect of that medication. So option 2, muscle cramps during ambulation. Definitely going to think this is our adverse effect. It's going to be related to our hypokalemia. Okay, we did it. Thank you guys so much for sticking that out. I know potassium and electrolytes in general are a lot to take in. We're going to keep breaking down these electrolytes for you as we go. So make sure and follow us on your favorite channel so you can get our schedule of the topics we're talking about. Next week, you have a great presenter, Mel. She's going to walk through some case studies, and then I'll be back with you guys on Thursday. Make sure you also go to nursing.uworld.com and check out our free trial. You'll get a real great taste of everything UWorld has to offer, from our questions, our explanations, everything. So we hope you'll try it out and keep up with all of this. Keep doing good in nursing school, and we hope to see you guys next week on Tuesday. Make sure, again, subscribe, like, follow, all the things UWorld Nursing, and we'll see you next time.